Hello everyone, today we'll be talking about pupillary light reflex. Now, the pupillary light reflex, to understand properly, we have to know the pathway, and then we'll be talking about the various lesions at the afferent as well as the efferent component of this pathway. Now, there is a little difference between the visual pathway and pupillary light reflex. So, what is the difference and where exactly the difference lies? Now this is the visual pathway. You can see this is the right eye supposing, and the light is thrown in the right eye. Once the right eye is stimulated with the light, the right optic nerve will be stimulated, and through which the stimulus will come and the nasal fiber will decussate at the optic chiasma. Now, the ipsilateral temporal fiber and the contralateral nasal fiber will come and continue as the optic tract. This optic tract will go to the lateral geniculate body, and this lateral geniculate body say there will be optic radiation, and this optic radiation will spread into the visual cortex. Okay, we have the Worm's loop, Meier's loop. We are not discussing the visual pathway. So in short, that is the visual pathway. Now what is the light reflex pathway here? You see, when the right eye is illuminated with the light, what happens? The basic difference that you have to remember here, that this optic tract, is having two kinds of fiber. Means till the optic tract you have the visual fibers and you have the pupillomotor fibers. You have the visual fibers and you have the pupillomotor fibers. The visual fibers are carrying the visual sensations, whether to see an object or not, and this will be relaying into the lateral geniculate body and then the optic radiation and visual cortex. But this pupillomotor fiber, that means it is taking the sensations, it is carrying the light reflex to actually cause constriction of the pupil. It is supplying by various connections, it is going to supply the sphincter pupillae muscle. So it is going to cause the constriction of the pupil. This pupillomotor fiber are leaving the optic tract. These pupillomotor fibers are leaving the optic tract and it is going to pretectal nucleus. This is the take home point. Pretectal nucleus, which is the center for the pupillary light reflex. After optic tract, in the lateral geniculate body, optic radiation, visual cortex, they are not related to my pupillary light reflex pathway. So let us learn the pupillary light reflex pathway. Okay, so once the light is there in the right eye, what happens? This sensation is carried out through the right optic nerve, and then what happens that through the temporal part of the optic chiasma, it is going to the ipsilateral optic tract. Now in the optic tract, as I told you, the pupillomotor fibers will leave the optic tract and go to the pretectal nucleus. So here you see this is going to leave the optic tract. See, this pupillomotor fibers are leaving the optic tract, and this is the pretectal nucleus. This is the pretectal nucleus, and this pupillomotor fibers are relaying into the pretectal nucleus. Okay, that is very important. So they are relaying into the ipsilateral pretectal nucleus. Now from the pretectal nucleus you have Edinger-Westphal nuclei. That is very important, and we have both sided Edinger-Westphal nuclei. Now from this pretectal nuclei it will connect to the Edinger-Westphal nuclei. So from ipsilateral pretectal nuclei, it will supply the bilateral Edinger-Westphal nuclei through the internuncial neuron. What are those neurons known as? These neurons. Okay, these neurons, the blue and the red one, these are known as internuncial neurons. Okay, so from the pretectal nuclei, okay, the light reflex stimuli is carried to the bilateral Edinger-Westphal nuclei. Now the Edinger-Westphal nuclei is a nuclei from which the third nerve will arise. So and from the third nerve will relay into the ciliary ganglion. Okay, and then from the ciliary ganglion our short ciliary nerve will arise, and the short ciliary nerve is going to supply the sphincter pupillae muscle. It is going to supply the sphincter pupillae muscle, and that is going to cause constriction of the pupil. Now if you see carefully, this is happening bilaterally. Okay, so if you illuminate the right eye only, your bilateral constriction of the pupil happening, that is what is known as consensual light reflex. Okay, the constriction of the same eye, which is direct light reflex, and because of this crossing over from the pretectal to the through the internuncial neuron to the Edinger-Westphal, is causing consensual light reflex. Okay, now if you see, if there is afferent defect, so what is the afferent of pupillary light reflex? The afferent is your optic nerve. The afferent is your optic nerve. You can see through the optic nerve, okay, your light reflex is carried. Okay, so if there is optic nerve or afferent defect, what will happen? The direct light reflex of the eye, the same side eye, the ipsilateral direct light reflex will be absent. And what about the consensual light reflex? The contralateral consensual light reflex will also be absent. Okay, because you see, because of the stimulation of the one right eye, the both people are getting constricted. If afferent is not there, so ipsilateral, this eye won't go. Okay, you can see this will not perform, this will also not act. Okay, so both the direct and consensual light reflex will go, but not of same eye. Please remember, the contralateral one go, because if you illuminate the left side, you will get consensual light reflex of the right eye. So please remember, if there is afferent defect, you will be having ipsilateral direct light reflex absent and contralateral consensual light reflex absent. Don't worry, we will be again revising these things. So again you can see from here, the light is thrown in the right eye. Okay, light is thrown here. Now this is your this pupillomotor fibers, they are going, these pupillomotor fibers are relaying into the pretectal nucleus. Okay, and through the pretectal nucleus it is relaying on both the Edinger-Westphal nuclei. Okay, now the internuncial neuron that is supplying the ipsilateral Edinger-Westphal nuclei is actually it has a bend over the periaqueductal gray, and the contralateral one that is supply the contralateral Edinger-Westphal nuclei that is supplying through the posterior commissure. Okay, it is not needed. Now once the Edinger-Westphals are there, now what is happening? You have the third nerve. So from the Edinger-Westphal, the third nerve is going, and the third nerve is relaying here, where the ciliary ganglia. Okay, now from the third nerve you have this short ciliary, and this short ciliary is supplying the pupil, and you can see the same thing is happening to the opposite side also. The same thing is happening to the opposite side also. That's why you are getting the consensual light reflex. Now 3 questions, fatafat answer de do. The afferent is optic nerve, no doubt. Okay, what is the efferent, guys? What is the efferent of the pupillary light reflex? This is the third nerve, na? This is the third nerve. So yes, efferent is short ciliary, but if they ask you the cranial nerve, obviously, so it is the oculomotor nerve. The third nerve, that is the oculomotor nerve. So second is the afferent and third is the efferent. Understood? Okay. Now they will ask you what is the center of this pupillary light reflex. As I already mentioned, the center is this one. Where? The pretectal nucleus. Here I mentioned the pretectal nucleus is the center of light reflex. So it is pretectal nucleus. Understood? Next question, they will ask you which is the side where crossing over happening. Okay, so please remember, if they have given the option of internuncial neuron, please mark it. followed by Edinger-Westphal nuclei. Okay, because many a times you will be having this option. Okay, so mark it. So after understanding the pupillary light reflex, okay, and the difference of pupillary light reflex and visual pathway, now we are going to learn various lesions involving the pupillary light reflex. Okay, so here we go. So we have the lesions here, and the lesions may affect the afferent pathway, lesions may affect the efferent pathway. Okay, so we have something that is known as the afferent pathway defects. The afferent pathway defects are known as APDs. So we have AAPD, that is absolute afferent pathway defect. That means here complete afferent means optic nerve is damaged. So if there is complete optic nerve is damaged, so obviously the patient will be having very important anopia. Is it? Yes. So the patient will be having anopia. What anopia? Obviously ipsilateral anopia. Next, please remember all the afferent pathway defects are presented as isocoria, means both the pupil size will be same. So there will be isocoria, very important. Okay, and what is the main clinching point? As I already told you, supposing if my right eye ka optic nerve is getting damaged, then if I say this is my right eye optic nerve, so this right eye optic nerve coming, and this is supplying ipsilateral Edinger-Westphal, and also from here the contralateral Edinger-Westphal, from where my short ciliary are supplied. This is just a line diagram. So it is getting damaged, so my ipsilateral direct light reflex gone and contralateral consensual light reflex gone. So this is very important, that ipsilateral direct and contralateral consensual light reflex, this will be gone, this will be absent. So that is what is absolute APD, absolute afferent pathway defect, which is also known as Amarot's pupil, which is also known as amarotic pupil. Okay, which is also known as amarotic pupil. Now we have relative APD, which is also known as Marcus gun pupil. Marcus gun pupil is where there is partial, so you can see this is a relative one, so it's a partial optic nerve damage. So here what happens, guys, that there is very important, the clincher, I am just mentioning the points which will clinch the diagnosis. Okay, so here relative, that means the optic nerve is functional. So initially it will when you do when you give light, the pupil will constrict, but as the optic nerve is damaged, so it will be fatigue after certain period. Okay, so it will not respond to light and it will remain dilated. So whenever you give light, there will be paradoxical dilatation. So please remember, if your question is saying there is paradoxical dilatation of bilateral pupils when you throw the light on the diseased eye, is what is your Marcus gun pupil. Marcus gun pupil. What is the diagnostic test? Here we do swinging flashlight test. Swinging flashlight test. Okay, so here supposing my right eye is defective, left eye is normal. Okay, so when I give light on the left eye, so left eye ka direct reflex will be present and right eye ka consensual reflex will be present or absent? Present, because it's an afferent defect, na? But present means both eye will constrict. But when I give light to the right eye, what will happen? My right eye is actually having the pathology, means the right eye optic nerve is partially damaged. So initially it will respond, but later when it is getting dilated and again you flash the light, understanding? So initially when you just give light for the first time, the right eye will constrict, the left eye will also constrict. Okay, but when you withdraw the light, again both the pupils will dilate. But again when you flash the light, again they try to constrict, but As the optic nerve is damaged partially, so the recovery period or the regeneration period from the recovery period is long. It is taking much longer time to recover. So in that meantime, the dilatation is predominating. So whenever you do this thing, so that's why it is swinging flashlight test. It is not just once you are illuminating with light. You are giving light and withdrawing it, giving light, withdrawing it. So by this method, you are actually uh, provocating the optic nerve to be fatigued. Okay, and once it is fatigued, it will not respond to light. So once you throw the light, it will paradoxically dilate, and as it is an afferent, so obviously both the pupil will be, you will be having this paradoxical dilatation. It is what is known as pupillary escape phenomenon. I don't know how much you understood, but this is the way. The clincher word is paradoxical dilatation of the pupil, both the pupils. Okay, and the test is swinging flashlight test. Okay, and this is used to differentiate between the amerotic pupil and Marcus gun pupil. Marcus gun pupil is very important. Okay, this is very important. The history may be given in diabetes or CRVO. Okay, these are the conditions where you can get it. Okay, and this is because of the fatigability of the deceased nerve. You see here, you will be getting this thing, but here flashlight में अगर ज़्यादा से ज़्यादा होगा तो paradoxical dilatation होगा. Next condition is Wernicke's pupil. What is Wernicke's pupil? It is associated with optic tract lesion. Now, as I told you, optic tract has got the pupillomotor fiber and visual fiber. So, whenever you have this optic tract lesion, what is happening? What is the visual field defect? In optic tract lesion, there will be contralateral homonymous hemianopia. Okay. And if I say this is the left eye, so if there is left eye pathology, so there will be contralateral means right sided homonymous, okay, hemianopia. So right sided homonymous hemianopia. Okay, that means this is the visual field defect. Okay, pura right sided homonymous hemianopia will be the visual field defect. Now, why this is important? Supposing this is a patient of optic tract lesion, and the optic tract is lesion, the lesion is at left optic tract. Okay, and the patient has this right homonymous hemianopia. Now, if you are demonstrating or if you are testing the pupillary light reflex in this patient, okay, by throwing light from this temporal side of the right eye, what will happen? If you throw light from the temporal side of the right eye, this is the right eye visual field, this is the left eye visual field. Now, if you are throwing light from this right side of the right eye or the temporal side of the right eye, so that will be like there is total afferent pathology. So neither the direct light reflex nor the consensual light reflex of the same eye and the opposite eye will be present. Okay, but once you throw light from the nasal side of the same eye, then the direct light reflex will be present, even the consensual light reflex of the opposite eye will be present. So understanding this is what is Wernicke's pupil. Here, because of the underlying contralateral homonymous hemianopia, the direct light reflex and consensual light reflex, they are varying even in the same eye, and they are dependent on the direction of the light thrown in the eyes. Okay, that is very important. Now please do keep in mind that in this apparent pathologies, the near reflex is normal. Okay, that means the accommodation reflex are normal. Now coming to the efferent pathologies. Efferent pathologies, we have ARP, that is Argyll-Robertson's pupil, and ADIE'S tonic pupil, and ADIE'S tonic pupil. Okay, what is Argyll-Robertson's pupil? Please remember that Argyll-Robertson pupil may you have ARP, that is accommodation reflex present, and PRA, that means pupillary light reflex absent. Okay, if the reverse is happening, that is what is inverse ARP. Okay, this is Argyll-Robertson's pupil. Very important association is neurosyphilis. Tertiary syphilis and neurosyphilis is a very important association here. The patient will be having this the accommodation reflex present and pupillary right reflex absent. Now, please do remember here this patient will be having the presentation will be bilaterally constricted pupil. Now, why there is bilaterally constricted pupil? The efferent pathway defect, but still there is constricted pupil. How is it possible? Okay, if you carefully observe, if the efferent pathway is defective, here the third nerve is here involved, so short ciliary is not supplying, so there should be dilatation, there should be mydriasis. But why there is bilateral constricted pupil on presentation? Can anyone tell me? Yes, because here is something complex understanding that Edinger-Westphal nucleus is something which is inhibited from the supranuclear fibers which are present in that midbrain, so this rostral midbrain. Okay, and as I told you, what happens in Argyll-Robertson pupil, there is a lesion in the rostral midbrain or periaqueductal gray, or there is lesion in the posterior commissure. Here I mentioned these two terms. Yes, I mentioned here in internuncial neurons. So these are the regions where these internuncial neurons are present. So basically Argyll-Robertson pupil means here is the defect. So ultimately what is happening, there should be bilateral dilatation or there should be anisocoria. But why there is constricted pupil? Because the Edinger-Westphal is inhibited by the supranuclear fibers, and the supranuclear fibers are present in this rostral midbrain. If the lesion is in the rostral midbrain, then supranuclear fibers gone, and this is giving inhibition to the Edinger-Westphal nuclei. Once the Edinger-Westphal nuclei are not getting this inhibition because of this fibers are lost, the Edinger-Westphal will be this will remain stimulated and will stimulate the third nerve, and third nerve to short ciliary, and short ciliary to the constrictor pupillae or sphincter pupillae. So on presentation, the bilateral constricted pupil, the accommodation reflex preserved, the pupillary reflex absent, and on the background of neurosyphilis is the diagnosis of ARP, that is Argyll-Robertson's pupil, is made. Also other associations like tabes dorsalis, aortic regurgitation, this can be associated. Very important. Inverse ARP I told you, that is basically seen in occipitotectal tract lesions. Okay, now here the patient is typically present with this feature, so you can rule out. Next is ADIE'S pupil and ADIE'S tonic pupil. How you differentiate this? So you can see neurosyphilis, accommodation present, pupillary reflex absent. Okay. Now what is tonic pupil or ADIE'S pupil? ADIE'S pupil is associated with herpes simplex, herpes zoster virus. Okay, it is associated with herpes zoster virus, and here the tonic pupil means the pupil on presentation, whichever eye whichever eye is affected, the pupil will never constrict and the unaffected side will constrict as normal. That means in tonic pupil, if I say this is my left eye and this is the right eye, and the right eye is where the lesion is, we'll be talking about where the lesion is, then what will be the clinical feature here? That if you throw light in this eye, this will remain dilated. Okay, this will remain dilated. So every time there will be dilatation. If you throw light in left eye, even this will be dilated, this will remain dilated. Okay, so this is on presentation, there will be anisocoria, there will be anisocoria. Okay, so on presentation, one eye is constricted or in normal pupil, another is mydriatic pupil. Light reflex is absent, the light reflex is absent in the affected eye, the both direct as well as consensual. Okay, the affected eye में होगा. Now why that is happening? This is because of the ciliary ganglion or short ciliary nerve involvement. So if the lesion is here or here, that means in the efferent pathway, so no matter you are giving light in this eye or giving light in this eye, ultimately to constrict this pupil you need this short ciliary or this ciliary ganglion intact. If it is not there, so your iris, your pupil will be in dilated, always will be dilated. So no matter it is on presentation, you are giving light or dark, anything. So this is what is tonic pupil. Supposing I am giving atropine to a normal eye. Once I give atropine to the normal eye, what happens? The pupil will dilate. This patient presented to me, how I will differentiate whether it's a tonic pupil or ADIE'S pupil or it's already a pharmacologically mydriatic pupil. This is very important. So in tonic pupil, there is pathology in the ciliary ganglion or short ciliary nerve. So if I see that the accommodation reflex are preserved, then it is a tonic pupil. But supposing I give atropine, and atropine is antimuscarinic and it is causing mydriasis, it's okay. But atropine is also cycloplegic, so which is paralyzing the ciliary muscles, and that is causing loss of accommodation. So anisocoria presented to you and you see that accommodation reflex present, so it's tonic pupil. But if the accommodation reflex is lost, then it is pharmacologically mydriasis. That means atropine is not only a mydriatic, it is also cycloplegic, so the accommodation reflex is lost. Add pilocarpine drop to that mydriatic eye. Now this pilocarpine first will be giving in a diluted manner, 0.1%. Once you give, what happens? The tonic pupil will start constricting. Okay, but your pharmacological mydriatic pupil will not constrict. Also remember, Argyll-Robertson pupil, it is not going to constrict. Even on myotics or mydriatics, it is not going to respond. Okay. Pharmacological mydriasis, on the other hand, you are increasing the pilocarpine concentration to 1%. Even on that concentration also it is not going to constrict, because atropine is so potent mydriatic, it cannot be reversed by 1% pilocarpine. As the tonic pupil, there is ciliary ganglion or short ciliary nerve damage, so obviously there will be a denervation hypersensitivity present, that will be absent in case of pharmacological mydriasis. Okay, so please do remember whatever I told you and enlisting whatever I just discussed. Any afferent pathway defect, the patient will be presented to you isocoria. Okay, now you see there is anopia, isocoria, and ipsilateral DLR and contralateral CLR absent. So it is amaurotic pupil, optic nerve damage. Now if you see that there is paradoxical dilatation of bilateral pupils on flashing the light, it is Marcus gun pupil. If you see there is optic tract lesion and the patient is responding sometime, and I mean the pupillary light reflex is present sometime, absent sometime, depending on the direction of the light flashing, is what is Wernicke's pupil. Efferent pathway में, if it is accommodation reflex present, pupillary reflex absent, neurosyphilis in the background, on presentation it is bilaterally constricted pupil, and there is light near dissociation. Light near dissociation, that means the light reflex absent and near reflex or accommodation is present, is what is ARP. Tonic pupil and ADIE'S pupil, tonic pupil or ADIE'S pupil, where you will be seeing anisocoria on presentation, and no matter the you give light on that affected eye or unaffected eye, this will remain dilated. Okay, the association is Herpes-Zoster or other neuropathies. Okay, and it is associated with the accommodation reflex present, there is denervation hypersensitivity, and it will respond to 0.1% pilocarpine. Pharmacological mydriasis, it will not respond to any myotic agent, and there will be loss of accommodation reflex. Supposing anisocoria is presented to you. Anisocoria means the difference of the pupil size that is more than equals to 0.4 millimeter. Then what will be the features? I mean, how are we going to diagnose the case? So supposing the patient is presented, okay, and we observe that this anisocoria gets worsen at night. So just think, at night what should be our pupil condition? At night, dim light, so our pupil should be mydriatic or mid-dilated, rather mid-dilated. Our pupil should be mid-dilated. Both the pupils should be mid-dilated. Okay. But if they are saying that anisocoria increases, okay, in the dark, that means one pupil is constricted, another pupil is dilated, because normal is dilated in dark. So anisocoria is increased means obviously one pupil will be constricted, and that means that constricted pupil will be the abnormal pupil. Supposing they are saying that anisocoria gets worsen in light. In light, pupil should be constricted. Both the pupils should be constricted. If they are saying anisocoria worsens at light, that means one pupil is dilated. That's why anisocoria is actually getting worsened. Okay, obviously meiosis will not get so much meiotic, na? So here in light condition, the dilated pupil will be the pathology pupil, or the site of lesion will be that side. Okay. Now supposing this is the condition, these are the two conditions, how we are going to approach. Okay, so here in our case the greater in the light, so the anisocoria in the light is getting worsened, that means the pathology is in the dilated pupil. So once there is dilated pupil pathology, so we will be looking for the shape of the pupil, and if there is any abnormality in the shape, then we can just take it as iris damage. Okay, but supposing the shape is normal, if the shape is normal, then I will be adding 0.1% pilocarpine, and I told you 0.1% may if constricting, then it is a ADIE'S tonic pupil. So in 0.1% if it is constricting, then it is what is tonic pupil or ADIE'S tonic pupil. If 0.1% may it is not constricting, then I'll increase the dose to 1% eye drop, and 1% pilocarpine may, I told you there will be no constriction in pharmacological mydriasis. If 1% may it is constricting, then it is a oculomotor nerve palsy. Okay, if they are saying that the anisocoria is increasing or getting worsened at night, okay, that means it is the meiotic pupil or the constricted pupil that is the site of lesion. Here we will be giving dilators like 1% apraclonidine. Now if 1% apraclonidine there and the pupil is getting dilated, that means what is the pathology? The apraclonidine there and there is dilation, that means it's a sympathetic palsy, and that is what is Horner's syndrome. In Horner's syndrome, that is oculosympathetic palsy, and there is sympathetic innervation to the pupil is lost. So the pupil cannot dilate. The dilator pupillae, that is supplied by long ciliary nerve, that is from the sympathetic supply, from the sympathetic nervous system. Okay, if that is getting affected, the pupil remains in constricted stage, that is in Horner's syndrome. Now suppose in 1% apraclonidine it's not getting dilated, so it is a physiological anisocoria. Okay, Horner's syndrome is very important. We'll be discussing about Horner's syndrome in a separate video. So this is the pupillary light reflex and the various pathologies, lesions of various afferent and efferent pathways, and how to approach various anisocorias. Thank you.